On behalf of the Association of State and Territorial Health Officials, also known as ASTO, I would like to thank you for participating in today's webinar entitled, Are You Ready to Sail Your Ship? Today's webinar is being recorded, and you will receive the link to review the presentation once we have it posted to our website. My name is Denise Pavletic, and I'm the Director of Public Health Systems Improvement at ASTO, and will be presenting and moderating today's session. This webinar is the second in a series of 4 webinars that ASTO is hosting on the topic of developing a state health improvement plan. Today's webinar is brought to you through funding and partnership between ASTO and the Centers for Disease Control and Prevention, Office of State, Tribal, Local, and Territorial Support. The content of this webinar are those of the authors and do not necessarily represent the official position of or endorsement by the Centers for Disease Control and Prevention. Additionally, the information provided in this webinar is intended to be consistent with FAB requirements and documentation guidance. However, ASTO cannot guarantee that states who follow this guidance will meet FAB requirements, as only the FAB site visitors can make that determination. Today's webinar objectives are to identify data inputs from the state health assessment and other areas to inform the SHIP process, identify resources for comparative data, understand asset mapping as it relates to the SHIP development process, and then understand ways to identify health disparate populations. At the conclusion of the webinar, you will be directed to a link to answer a few questions on how well we've met these objectives. In the spirit of our own QI, we very much value your feedback, so please take a few moments to complete the evaluation. We're very excited here at ASTO to bring you today's webinar, and we look forward to a robust Q&A session at the end of the presentation. So if I can take a moment to orient you to our ReadyTalk platform, there are 2 ways in which you can submit your questions. The first is through the chat function located on the lower left corner of your screen. You can submit questions at any time throughout the presentation using this function. So let's start off by trying to get some audience participation using this chat feature. Right now we have approximately 40 people on the webinar. So through the chat function, let us know the name of your agency as well as your location, and I can start. So let us know where you are. Great. Arkansas, Maine, Utah, MPHI, Michigan, Minnesota, California, great. Puerto Rico, hello. Nebraska. I'm not calling out everyone's name, so please don't take offense. Great. So it looks like we've got people throughout the nation. It's really exciting again to have you on board. And so as I indicated earlier, feel free to use that chat function as you have questions throughout the presentation. Okay, next slide please. The other option is to actually do ask an audio question. So if you'd like to speak to our presenters directly, we have ample time at the end of the presentation for you to do so. What you'll need to do is hit *1 on your telephone keypad, and the operator will put you in the queue to ask your question. And our presenters are excited to speak with their peers directly, so we definitely encourage you to use this function. So our presenters today, first presenter is Sylvia Pirani. She directs the New York State Department of Health's Office of Public Health Practice, which leads New York State's State Health Improvement Plan. Ms. Pirani oversees the office's provision of technical, administrative, fiscal, and data support to New York's 58 local health departments. She also oversees an initiative to integrate performance management and quality improvement into the state's public health programs, and led the department's successful application for public health accreditation in 2014. So congratulations to our colleagues in New York for being accredited. Ms. Prani has a master's degree of public health and a master's of science in urban planning from Columbia University. Next slide. We have also with us Preeti Irani. She's a research scientist with the New York State Department of Health's Office of Public Health Practice, and also serves as the State Healthy People 2020 Coordinator. Ms. Irani assists with the implementation of the Prevention Agenda, again that's New York State's Health Improvement Plan, and reviews the plans submitted by hospitals and local health departments as required under public health law. And our third presenter is Dr. Trang Nguyen. She's a Deputy Director, Office of Public Health Practice, New York State Department of Health. Dr. Nguyen directs efforts on providing New York State public health data for their State Health Improvement Plan, tracking dashboard and community health needs assessments at the state, regional, and local levels. Dr. Nguyen received her Doctorate of Medicine degree in Vietnam and her Doctorate of Public Health in Epidemiology from the State University of New York at Albany. Okay, so let's just jump in and talk a little bit about, give you a little bit of a background on the development of our SHIP, developing a SHIP guidance and resource. So ASTO released the Developing a SHIP Guidance in the summer of 2015, and that was a sequel to the State Health Assessment Guidance and Resources that we released in 2014. These resources were developed in conjunction with our partners at the Illinois Public Health Institute and involved an expert advisory panel consisting of state health agency representatives from across the nation. So where do you find this resource? First, go to www.asto.org, click on Programs, and then click on Accreditation and Performance. This will bring you to the Accreditation and Performance landing page, where you will click on Tools Clearinghouse under the Resources tab. That will bring you to the SHIP landing page, where you will click on the download link. And to give you a heads up, before you are able to download, you'll be directed to complete your name, agency name, and email address. And we're using this information to provide follow-up on the toolkits as well as to use for our evaluation. A little bit about what's in the State Health Improvement Plan guidance. It has 7 modules: identifying and engaging stakeholders, engaging, envisioning, and systems thinking, leveraging data inputs, establishing priorities, communicating SHIP priorities, developing objectives, strategies, and measures, and implementing and monitoring the SHIP. Last week we covered modules 1 and 2, and today we'll be covering module number 3. And then within each module, it contains a preview of the content, the relevant FAB standards and measures, ideas for structuring the planning process, important considerations, key terms and acronyms, and then most importantly, state examples and lessons learned. And then we have sample tools and links to resources throughout the document, as well as cross-reference to our State Health Assessment Guidance and Resource. So here's an example. Each module has an extensive list of resources and links related to the module topic. Each module contains the relevant reference to FAB Standard 5.2, as well as references to other standards related standards throughout the resource. And last, each module contains a section on important considerations, again with links to relevant resources. Okay, before we jump into Module 3, let's get some more audience participation. So we have our question for you is, where are you in the SHIP process? So please just select the best answer that describes your agency. Great. Well, we have half of our folks on the line have already completed their SHIP. That's great to know. And then it looks like it's a even split between we haven't developed our SHIP and we've begun prioritizing our data, and we have an advisory committee. Great. That's excellent. Thank you so much for sharing. All right. Let's jump into the guidance in Module 3. During the SHA process, the State Health Department and partnership developed key findings from assessments and data collection and analysis. The SHA data and key findings should be the core used to develop the SHIP. There are a number of data inputs that the State Health Department and the SHIP partnership can leverage for the planning process, including SHA reports such as stakeholder identified issues and themes, systems assessments such as the National Public Health Performance Standards, community and regional level data and assessments, monitoring and surveillance and evaluation data, statewide data summaries, national rankings, inventory of assets and resources, data analysis to identify populations experiencing the greatest health disparities. And these data inputs will be used throughout the SHIP planning and implementation process. So let's quickly walk through the 5 areas I just talked about, the 5 sources for data. The first source could be community level and regional level assessments and plans. So Healthy People 2020, one of the objectives there is to increase the proportion of local jurisdictions that have linked health improvement plans to their state plan. Many states report that community and regional level assessments and plans are very valuable input for the SHAs, and if not included, they should be in the SHIP process. In order to maximize alignment between statewide priorities and initiatives and local and regional efforts, there must be continuous communication and collaboration related to community health data. So many states are developing processes for tracking and compiling local data for state health improvement planning. And what you see here in this slide is taken from our guidance document, Figure 3.1. It's a matrix that Washington State has developed that contains links to their local health agency assessment plans. Second piece of data is existing monitoring, surveillance, and evaluation data. If a state already has an existing SHIP, data or results from the monitoring and evaluation of strategy implementation and progress towards objectives, these will be very important inputs for the SHIP prioritization and planning process. The inputs will provide baseline data to achieve objectives for improving health and determining effective strategies. Second is statewide data summaries for specific issues. So data summaries are intended to inform and support partners' health improvement efforts at the state level. However, FAB Measure 1.4.2 requires the production of statewide summaries or fact sheets to support health improvement planning processes at the state level. These summaries or fact sheets condense the state's public health data but are not the same as a community health assessment. Next, a bit on national rankings and dashboards. In addition to looking at the local and regional data within the State Health Department and SHIP partners should also reference comparative national data and peer-to-peer comparisons with other states. Such comparisons may already have been used in the SHA, but they have continued utility in the SHIP planning process for developing objectives and targets and ongoing monitoring of implementation results. Next is our inventory of assets and resources. Asset mapping can be another helpful tool for moving from the assessment and planning stages to action. The SHIP partnership can use asset maps developed during the SHA process or create them if desired. Through the development of supportive, reciprocal relationships between community residents, organizations, and institutions, the SHIP partnership can leverage existing resources and capacities to improve health. And again, another feature in our guidance document, Figure 3.3, outlines the 6 components of asset mapping. Define the scope of the asset map, define the community, do the initial scan to identify assets, and then a more thorough scan including referrals to other assets, assess the strengths and weaknesses of those assets, and then identify the gaps. Per the guidance in our State Health Assessment Guidance and Resource document, the State Health Assessment will produce data and information about health disparities related to health outcomes, risk factors, and determinants. And the data will be of critical importance for prioritizing and selecting SHIP priority issues. As the SHA data is being presented to stakeholders and the public, the SHIP partnership can gather additional input and information related to disparities and priority populations. So those are some of the highlights from Module 3. And so I'd like to turn it over at this point to our friends and colleagues in New York. So Sylvia, I'll turn it over to you.
Thank you very much, Denise. We're really pleased to be here in New York to talk about the work that we did as a team to conduct the State Health Assessment, which led to our State Health Improvement Plan. It certainly was a big team effort, and Priti and Trang led significant portions of this, so we're pleased to be able to share everybody's work. So on the next slide, I just want to briefly show you how this work fits with Domain 1. As Denise talked about, this is standard 1.1, measure 1.1.1. When we applied for accreditation, we were using version 1 of the FAB standards, but this reflects the language in 1.5. And so the first part of this is that you need a state partnership to conduct the assessment. That's a theme in FAB's work, as you all know by now. And then, and with that partnership, you need to have a lot of participation from a variety of sectors, regular meetings, and you need to document that communication with them. And you need to have a process to identify the health issues and assets. The next slide shows another important measure 1.1.2, which is what's required in the state level health assessment, the state health assessment. And we followed this to a T. And again, it was we followed the standards in 1.0, but these are not that different. We took this list and said, okay, this is what our state health assessment is going to look like, because we were interested. We did this with the purpose of applying for accreditation and completing those 3 prerequisites, the 2 here being the health assessment and the health improvement plan. So we had A through E and did our outline that way. And then we built into it a process for people to comment on what we were looking at and an opportunity to monitor and refresh and add data. So the next slide gives you a little background on our process in New York State. We had a prevention agenda for the period 2008 to 2012. Before that, we had also something that could have been called a State Health Improvement Plan called Communities Working Together. But we started with the prevention agenda theme in 2008 and have continued that. Our current plan is for 2013 to 2018. When originally developed, it was a 5-year plan as per FAB standards. We've been asked here to keep it in line with some other state health reform initiatives that we have going on, so we've extended it to a 6th year. So we'll have to figure out how to meet the FAB issues about having one every 5 years. I mean, we're continually updating it, so I think that won't be an issue. We did the development of the work in 2012, and we used data and progress to date or lack thereof in our indicators for the first prevention agenda cycle. So we assessed the progress and accomplishments and challenges of that cycle and used that to build into the assessment and then the plan. And you can see all the information on how we developed it on that link on the slide. And we finished everything in 2012, and we submitted that with our application. We have been working closely with a range of statewide organizations to help us with this. This was certainly before we realized that FAB would be requiring this as well, but we've had the benefit of working with this statewide ad hoc leadership group. It's a ad hoc committee to our state's Public Health and Health Planning Council, which is like our Board of Health. It is chaired by the Joe Ivy Buford, who is the president of the New York Academy of Medicine and led one of the IOM reports on improving the public health infrastructure. So we're very happy to have her as our leader. You can see the organizations there. It also includes some other state agencies, including the Office of Mental Health and the Office of Alcohol and Substance Abuse Prevention Services, who are our partners on this, and one of our priorities relates to mental health and substance abuse, as will be discussed later. And so we put together our assessment and went to this group to help us get feedback, both from them as representatives on the ad hoc committee as well as all of their members. The next slide talks about our timeline. We conducted the state health assessment in 2011 and early 2012. Presented the data to our stakeholders in February 12 to help us finalize the 5 priorities. We came up with a set of priorities, but they finalized it with us, and they changed them certainly to reflect their views and thoughts on the data that we had collected. So now I'm going to turn it over to Dr. Trang Nguyen, who's going to talk about this process in more detail.
Thank you, Sylvia. Next slide, please. I'm going to talk about the first document that we produced, and the 2 documents in the previous slides. You can access them on the website. The link for the first document is right here. It's our progress on the Prevention Agenda 2008 to 2012. For the previous SHIP, just a little bit background, the goal was to improve the health status of New York's population on the 10 priority areas. And to assess the progress, we collect data from primary and secondary data, as well as quantitative and qualitative data. Can you go back one slide? Thank you. And then, so for those data, we collected the collaboration information on collaboration between the local health departments and hospitals on the implementation of the local health, the local community health improvement plan that they selected in the previous state SHIP. And then we also assessed on the outcome data on our leading indicators in the 10 priority areas. You can go next slide, please. So in terms of the, I'm just going to select some of the slides to show you the different type of data that we collected. For the local health departments, we have 58 local health departments in the state. So they were required to work with hospitals and community partners to develop and implement their CHA and CHIP. At that time, it was called Community Health Assessment and Municipal Health Service Plan. And then the hospital, we had at that time 165 hospitals that they were also required to work with local health departments. together on the local community health issues. And the hospital came up with their plan called Community Service Plan. So we assess those information. Next slide. And from here, we can see that for the local health departments, out of 57 out of 58, we collected the data. And the priorities that they work on, some are highlighted here. The leading one is the chronic disease, access to health care, physical activity, and nutrition. And then you can see the rest, they selected less. Next slide. And these are the hospital priorities. We also see that the same three highest areas were selected as chronic disease, access to healthcare, and physical activity and nutrition. Next slide, please. And we also assess the partners that the local health department said that they work with besides the hospitals. And here the distribution, they work a lot with community-based organizations, with healthcare providers, with university and business. Next, please. And here is the partners for the hospitals at the time. Similar pattern. Next slide. And then we also asked them on the priority that they selected in their 2010 plan is that, where they at in their planning their actual interventions. And we assessed, most of them were in implementation phase. Some were in evaluation, collecting data, and then a good amount of hospital, local health departments still in the planning phase. Next slide. And then we also asked them about what they have done to implement the strategies. And here are some of the results. Each of the local health departments at the time was asked to address minimum of 2 priorities. So here's the steps that they taken to address both priorities, or only one priorities, or neither priorities. And then you can see that a lot of them that answer will building, strengthen partnerships, and then fewer toward the end, evaluate intervention that has fewer. Next. And we also asked them about, this is a qualitative part, asked them about the challenges that they face while planning and implementing their community health improvement plan. And a lot expressed about funding, competing public health priorities, adapting evidence-based intervention to local setting, identifying and using short-term improvement measures to assess the progress. So these are the major challenges that that reported from the our partners. Next. And then we also assess the progress to date on the 51 leading indicators. And this is a summary slide on we saw improvement on 35 indicators. In that we have 3 indicators achieve the targets, and we have 14 indicators moving into the wrong direction. 1 indicator is unchanged, and 1 with no data. And we saw that disparity was not improving. Next. So then that was the assessment of our previous shifts. And so when we start working on our state health assessment for this last cycle, we follow, like Sylvia said, we follow really strictly with the FAST standard, and it actually turned out very helpful for the accreditation board when they review documentation and against the standards and the measures. They found the document very easy, to follow, and so that was one of the things that we thought that that our lesson is a positive lesson learned. So basically, the first 2 components of the The SHA is the description of the demographic and description of health issue. The link here, you can see the documents that we developed and posted on our website. Next slide. So basically, this is the first among first couple pages of our description. You can see that we assess a series of health-related indicators, not only just health, but we also assess the population, poverty, access to health care, education, disability, and other factors, health determinants. And next slide. And then we go on into the description of some the general health outcomes among our population. And then we also go into detailed topic areas such as for maternal and infant health, infectious diseases, chronic diseases, mental health and substance abuse, and health risk behavior. For each of these, we present our data. We get trend data where possible to see where the state population is it going improving or getting worse. We compare our data with the U.S. and Healthy 2020, People 2020 objectives where available. We also assess disparities by different subpopulation groups by race, ethnicity, gender, age group, and then we also assess disparity by geographic region where we look into all of the county in the state. And you will see in the next several slides where we demonstrate those the data, but we just selected several slides to demonstrate this. Next, please. So, for example, in here you can see we compare the distribution of our population. The left graph show you that the population of New York State looked in 2000. And in the right side, you see the graph for 2010. We recognize that we facing an aging population where you have more of the population going into age group around 50, 60. So we're dealing with more aging population. That means that a lot of chronic conditions and mental health conditions. Next, please. We also look into the diversity of our population. Of course, we have very diverse population in New York, and we have about 60% of white and Hispanic, but we have good proportion for Black, non-Hispanic, and Hispanic, and we have a growing Asian population as well. Next, please. And here we look into the changing in our population between 2000 and 2010 to anticipate for different factors and different issues that come with different populations. In here we can see the fastest growing population is the Asian non-Hispanic. The second group is the Hispanic group. Over the 10 years, one increased 36% and the other increased about 20%. Next, please. And we also look into income data using census data, and we compare New York State with the U.S. And different indicator of poverty. Next. Here we also looking into poverty, but looking across the state to see, you can see the distribution is very, some in the urban area and some in the rural area as well. The dark color represent higher percentage of family living in poverty, and the lighter color is the lower group. Next, please. We also look into education. Actually, the education is one of the indicators that we rank. We don't rank very high on the America Health Ranking, so we definitely want to take into account education and high school graduation rate, and also to work with our partners to improve this. Next, please. So then we're going, after describing the demographic of the population, we start describing some of the general health issues that the New York State population are facing. We look into leading causes of death. Our highest leading cause of death is heart disease, followed by cancer, and then we're going into some the other around stroke, lower chronic disease, lung disease, pneumonia, and then injury also an issue. Next, please. Now, although we look into each of the specific groups of health outcomes, this graph look into the death rates due to heart disease, by race, ethnicity. We see an improvement, downward trend for all race, ethnic groups, but still we have a lot of work to do. Next, please. Then we also look at the geographic disparity to identify the county, the places that have highest burden. And again, the color indication is that light color is the lower burden, and the darkest color is the highest burden group. And the way we did here is we put them into quartile, and the darkest color is the top 25% of the counties, and the middle group is also 25. The next 25% second highest quartile, and then the light color is half of the counties, and that way we look across all health indicators that way. Next, please. An example of infant mortality rate, we compare New York State over time as well as with the U.S. The New York State was at lower than the national average, and we just met at the time the Healthy People 2020 objective. Next. Then we're looking at by race, ethnicity, even though for overall population we met the Healthy People, but here we identified that the Black non-Hispanic group still have much higher, like double the Healthy People 2020 objectives. So we still have a lot of work to do, especially among this population. Next. Then we also look again across the local communities throughout our counties and identify counties with the highest infant mortality rate. Next. And then some of the other conditions that we also look at because it affects a lot of chronic health conditions. Obesity is the one that we specifically interested in because we have a upward trend with the adult population. It's a similar trend probably for other states in the nation, but it's something that is one of our top priorities. So we look into obesity among children and obesity among adults, and then we identify this as a priority for us. Next. And here's the map that has the prevalence of obesity among adults across the state. Again, with the dark color indication of high rate for obesity among adults, and some of the rural area actually, and upstate counties has a higher prevalence of obesity among adults. Next. We did also calculated a disparity index among our top indicators and identify areas where we have a variation by race, ethnicity in this case, and rank them among a series of health indicators. Again, you can see more of these data on our website, and the link that I provide you will be for this series of slides. Next. So with all of the information that we compile and we share it, we share the information with our stakeholders through series of meetings to use the information to select the priority. And here are some of the criteria that we use for selecting priority. We use, based on disease burden. We also consider in the areas that there are evidence-based or promising or next practice interventions to prevent the cause of the health problem. We assess the feasibility in terms of resources and infrastructure to address the problem. We also based on community and partner available to support the intervention. And then also consider if the health department have leverage to make changes in certain areas, and where we can also move the needle on health disparity, and also where we can monitor specific and quantifiable by quantifiable measures. So these are the criteria that we as the whole group with our stakeholders identify and working together with the data to identify the priority moving forward for our current shift. Next, please. So now Preeti is going to talk about how we share the information and work with partners.
Right. Everything that Trang did so far, she presented the data like in late December. So by January, the ad hoc committee, the public health committee, had seen this. And, you can only have a limited number of people. The meetings were held in Albany or New York City. And this is a big state, and people always want to be on everything, and they want feedback, and we want the feedback. Like Trang said, we had seen the reports submitted by local health departments and hospitals, but now we needed to talk more. But there were a couple of limitations. In first step, this was done in January, so we were in the middle of winter, so traveling is going to be difficult. We had to get this out by the end of the year because our last prevention agenda was going to end, and so we needed a new one. But we also wanted to apply for the accreditation process. So keeping all this into consideration, we decided maybe the best way to get the stakeholder feedback was to use our ad hoc committee members and also have a survey. So what we did is we did a survey in SurveyMonkey, basically asking what Denise had said earlier on, trying to get what our assets are, what our strengths are, what our challenges are. So the first 3-4 questions you see were questions on the survey. At the bottom of the slide, you see a link which gives you more details. But we asked them what the strengths are, what are the challenges, what suggestions they have for us to work through the challenges, and what issues they would like to see addressed in the year. We got good feedback, but we did not want to totally depend on people going to a survey and putting in their responses. So the ad hoc committee members who represent various factions throughout the state went to their people that they work with and presented. And so the next set of 5 questions we had for our facilitators. So when they had community meetings, we had given them a presentation, kind of a slide set. They could present and ask questions, very similar questions, but a little more probing about strengths, challenges, what they saw with difficulties with our last community assessment and what suggestions they had. So if I can have the next slide. So what did we get from the stakeholder feedback? We went through maybe about 50 different groups. So all these different groups would talk with people anywhere from 5 to 50, and they would put their feedback back on the survey that we had put. And we also invited people who couldn't be part of the group to provide feedback. And we looked at themes, what were they saying? So that the key themes or the strengths was based on our last prevention agenda. They liked it that the priorities were specific and they had like data and objectives and goals. And they liked the fact because we had started in the last round in 2008 encouraging local health departments and hospitals to collaborate on at least 1 or 2 priorities and work together. The challenges, again, kind of on one side they say it's specific, And the other side, they say it's too broad. For example, they thought access to care was very broad. And then they said resources, funding and getting kind of current data was, our data could sometimes be old, were challenging. They said to address the challenges, we should focus on disparities and social determinants of health, and not only include long-term indicators, but also intermediate measures. Measurement was a challenge. And so based on that feedback, the 5 priorities that seem to emerge, which are our prevention agenda priorities, is prevent chronic diseases, promote a healthy and safe environment, promote healthy women, infants, and children, promote mental health and prevent substance abuse, and prevent HIV, STDs, vaccine-preventable diseases, and healthcare-associated infections. Again, this detailed feedback is on the website, and the link is below. And I'm going to turn it back to Trang.
Thank you.
The next slide, please.
Right. So as you can see that the data was shared and discussed and with the stakeholders across the state, and to identify the 5 areas of priorities for the state moving forward. After that, we go on and develop the next 2 documents, or that help as a part of the SHA. They are the contributing cause of health challenges and summary of state access. So we develop each of these for each of the 5 areas, the priority area that we identified. And then we use this document to support the selection and development of our state health improvement plan intervention strategies and recommendations, as well as identify the tracking indicators to monitor the progress of our implementation. Next. So when we develop the contributing causes of health challenges, basically the format of each of the priority area is that we develop the background, more detailed background of the health priority identified. We get more health burden and trend data, and we get into more disparity by socio-demographic characteristic, as well as by geographic disparity, so that we can identify areas with high burden of certain conditions. And then we identify risk factors so that we can work toward the causes of the problem. And then we also identify challenges in addressing these diseases conditions so that we can develop strategy and policy to address the challenges where possible. And the link to I'm not going to go into detail about each of the document, and you can find our document on the link on the bottom of this slide. Next, please. And same with when we develop a summary of the state access, we identify programs within the department and also partner within and outside that are available and can contribute to policy and existing resource for each of the health issues to address in the 5 priority areas. In that we, this document, the link is here. And in addition to this is a very brief access at a high level of summary, but in addition to this, we also identify the local partners and local contractors that the department and partners fund, local contractors such as the WIC program or HIV contractors with the address and the name, so that we can post on our website. And we actually have that link as well, but we update that very often so that our local community can identify existing resources and contractors that already get funded to do these interventions so that they can make connections. And as well as we later on, I can show you the link where we will also post our local health departments, community health improvement plan, and also hospital community service plan that are updated every 3 to 4 years, so that the partners can find the local plan easily and know what they work on so that they can partner with. Next, please. So in terms of using data to support the implementation of our state health improvement plan, the first one is we develop a what we call prevention agenda tracking dashboard. As I mentioned before, out of the 5 areas, the documents that we develop with our partners were used to not only identify strategy and policy interventions for those priorities, but also used to identify the indicators. And out of a series of health indicators in each area, we selected about 10, 15 indicators per priority. And in their plan, they had more than these indicators, but we selected the leading indicators to include in our tracking dashboard. And here's a link to our interactive tracking dashboard, where we update the data at the state and county level. And the state level, we have 96 indicators. County level, we have 68 indicators. And at sub-county level, we have 11 indicators. And from this link, you can we update it every year, and you can look around when you have time. For the second source of data, we collect the updated local community health assessment, community health improvement plan from the local health department, and the community service plan from the hospital. And we also collect the annual progress on the implementation of these entities. And the data is, the summary of the report is posted on the link on the second bullet here. And then we also, on a regular basis, Sylvia and myself and others, we present our findings of both the tracking indicators as well as the progress on implementation of the local CHIP and CSP, CHIP and CSPs to the stakeholders. And here's one example of how we presented in 2015. But we have many of these presentations to give them updates as well, engaging them in the implementation of the state improvement plan as well as local plans, and also to support whatever they new issue that they have. Next, please. So this is just a screenshot of our dashboard where we have the state level dashboard on this slide. We have 5 priority areas, and then we have one overall health overall area to monitor the improvement overall. And this is an example of the prevent HIV, STD, and vaccine preventable disease and healthcare associated infections. You can see that we have the state compared to our prevention agenda 18 objectives, and the graph here with the red and green bars show that some of the measures we met the objective, and where we have both green colors bars, and where we have the state current data with the red bar, that means that we have not met our objectives, and we keep updating data and monitoring the progress against our objectives. And from here, we also can see the local data by clicking onto different data views. We can see county map and tables and graphs and trends. Next, please. And here's our county dashboard. Like I said, we have 58 local health departments, but we have 62 counties. And each of the counties have their own dashboard with very consistent look here. And from here, we can, from the county dashboard, they can monitor their county most recent data against the state, and then also the prevention agenda 2018 objectives. And the next slide. So when you go into the trend, the county, showing improvement, you can click on it and you can see the county trend data and see how the improvement was made. And also you can select different indicators to see different trend for Albany County in this case. Next. And we also, like I said, we had selected indicators where we were able to have the data at below county level. In this case, is the preventable hospitalization at zip code level, so that we can help our local health department and hospitals to identify areas with higher burden of preventable hospitalizations, and they can focus their limited resources to conduct intervention in those areas. Next, please. I'm going to turn back to Sylvia to talk about our experience with the accreditation application and site visit.
Thank you. So these are some of the quotes here from our accreditation report by the site visit team. They were impressed with our partnership and our stakeholders and community organizations, some of whom participated in the site visit. Those of you who've gone through this know that that's a good thing to do, is to have your partners come and say positive things about you. We didn't bribe them at all. We thought it was pretty genuine, their support. They were pleased overall with the prevention agenda and could tell that it was really not just a state health department plan, but really a statewide plan that was owned by and supported by many different stakeholders. And they were pleased with all the work that had gone on. And again, I want to say this was really a team effort. Trang and Priti led very important components of this, and that we couldn't have done it without a strong ad hoc committee. So putting together your stakeholder support is essential for being successful. And then we really followed the FAB recipe for what to include. Did not really steer from that. Had a little bit of support from the Robert Wood Johnson Foundation to help us put the plan together, really not the assessment as much as the plan. But other than that, it was really the hard work of my colleagues here who made it happen. We did not have a lot of new resources for the prevention agenda. So thank you. I think that concludes our presentation.
Well, thank you, Trang, Priti, and Sylvia. Very much appreciate all your hard work in terms of developing your SHIP and with your FAB accreditation. And then thank you for sharing your journey with us. So operator, can you open the lines to queue up questions?
Yes, ladies and gentlemen, if you'd like to ask a question, press star then 1 on your telephone keypad.
Great. So while we're waiting for that, we did have a chat question to come through from Haley Stewart. She asks, how did you construct the disparity index? So any one of you who can answer that, go ahead.
Yes, so the example that I gave, this is Trang. The example that we gave, we use the, disparity you can assess by different variables. In this case, we did it disparity among race, ethnicity. So we calculated the variation. We have the formula we can share with you, but basically in a lay term it's the variation of different subgroup by race, ethnicity with the burden of disease compared to the average, compared to the state average. So
thank you.
Variation, I'm sorry, to say if you have 1 or 2, 3 groups that have the burden that's far or higher than the average, the farther from the state average, the bigger the index will be.
Great, thank you, Trang. Holly, do we have any questions queued up?
We do have a question from the line of Joya Kaufman.
Go ahead, Joya.
Hi, Denise. Hi. Thank you so much for sharing this information about what's happening in New York. I did have a question, and I know today's presentation is focused on the data, but I'm wondering, how did you collaborate with your locals in terms of identifying and submitting data, and how did you engage them? Did you pull mostly from the dashboard, or was there a process, a different process that you used to get the state level data and then to discuss it with them, and how you talk about how you're going to move forward?
So I could start and just say that local health departments and hospitals in New York State, as they are probably in many states, are required to go through a community health assessment and health improvement process on a regular basis. We have it in state public health law in two different sections, one requirement for local health departments, another for hospitals. And so we had that. We knew about their experience with both the data they were looking at as well as the priorities they had worked on in the previous cycle, and used that to help us inform the priorities moving forward. So that's one part of the answer.
Mm-hmm. The other part is we utilize the state-specific data sets as well as the data sets collected by CDC. For example, we have our hospitalization, ED data, birth records, death records. That's where we can generate the data at the state level as well as the local level. So most of them at the county level, and then some of them at sub-county level where we have enough data. That's the data around the health outcome of the population. We also use our behavioral risk factor surveillance system, but there were a couple of years where we had state funding to conduct an expanded survey using most questions from the CDC, BIFSSS questionnaire, but we added some state-specific questions, but we were able to expand our sample to, I think, about 35,000 instead of regular 5,000 to 7,000 a year. So we were able to use that to assess a lot of the health behavior, health risk for factors for different conditions at the county level. The other part of that's presented on the dashboard. The other part of collecting from the local data is our annual report of the implementation of the community health improvement plan and the hospital community service plan. So we collect data on the implementation, and moving forward, we plan to collect more information on how they evaluate and assess the progress of the local implementation.
Thank you.
Great question, Joya. Thanks. We've gone a little bit over our allotted time. So if there are further questions, if you would just email me, and if you could do the next slide, Alex. If you could email me at dpavletic@asto.org with your question, I will get those to our presenters and then get back to you with answers. Again, I want to thank our presenters for a great presentation. Of course, we want to thank our funders as well as you, our participants. If you're in need of further information about developing a SHIP, you can contact me at the email address listed on the slide, and then webinar slides and the audio recording will be made available to you, and we'll send that out once it's been posted to our website. Once again, we value your feedback, so please take a few moments to provide us with your feedback on today's webinar. Thank you, and that concludes today's session. Have a great day.